Hi everyone, and welcome to today's webcast hosted by Clinical Directors Network. My name is Sindhu. For today's webcast, we are featuring Dr. Kelly Smith, who will be presenting on the Guide to Improving Patient Safety Through Primary Care Settings by Engaging Patients and Families, the Teach Back Strategy. Kelly Smith, Ph.D., is the Scientific Director of Quality and Safety Research at MedStar Health Research Institute and MedStar Institute for Quality and Safety. Her research focuses on identifying and overcoming lapses in patient safety and improving quality of patient care through innovation and collaboration. Notably, she is a leading investigator in patient partnerships and quality and safety research. Dr. Smith is the principal investigator of the AHRQ Guide to Improving Patient Safety in Primary Care Settings by Engaging Patients and Families. Dr. Smith receives research funding from the Agency for Healthcare Research and Quality, National Institutes of Health, and the Association of American Medical Colleges. At any point during today's session, please type any questions you have for Dr. Smith in the chat box located at the bottom right-hand corner of the screen. You may see a purple tab located at that corner. Once you select it, you'll pull out a white panel. At the bottom, you'll see a little chat bubble icon, and that will generate the chat box. Your questions will be answered at the end of the presentation. In addition, anyone who wishes to obtain CME credits for their attendance today should stay on after the question and answer period, and a link will be posted for the assessment into the chat box. Now I'd like to give our time over to our presenter, Dr. Kelly Smith.
Hello, everyone. Good afternoon. Thanks again to the Clinical Directors Network for inviting me today to present about an exciting project that we are working with the Agency for Healthcare Research and Quality on called the Guide for Improving Patient Safety in Primary Care Settings by Engaging Patients and Families. This is a really important project, and we are talking today about Teach Back, which is one of our first interventions for the guide that we're going to be disseminating. So the objectives for today's presentation include reviewing some of the key threats to patient safety in primary care settings, as well as some interventions to engage patients and families to improve patient safety, describing the role and the value of Teach Back in improving patient safety, and identifying some strategies for implementing the Teach Back process in primary care settings, and some tactical tools that we've developed as part of our guide work for the Agency for Healthcare Research and Quality. So I wanted to give you a little bit of a background on what the Guide for Improving Patient Safety in Primary Care Settings by Engaging Patients and Families is. It is a contract funded by the Agency for Healthcare Research and Quality to build a guide to improve patient safety and specifically focusing on interventions and strategies to engage patients and families in that process. As part of the project, my co-principal investigator is a patient and a patient advocate. So together we really bring the two worlds of research and practice and the patient experience to bear on this project. The goal for our project is really to build meaningful engagement with patients and families in ways that not only impact safety, but will also impact quality. The interventions are evidence-based. So all of the interventions that we've selected as part of the guide or have been selected as part of the guide have a strong evidence base on their improving health literacy, patient engagement, and patient and family partnerships. We wanted to make sure that the tools are easy to use so that practices can really focus on engaging patients and families and not on trying to implement a really difficult strategy. And we're looking to focus on practices that may not have done a lot in the area of patient and family engagement to help them come and take them to the next level. We have several key project deliverables. The first project deliverable was an environmental scan where we did look at the what's in the environment, and we focused on interventions specifically targeted to patients and families as well as primary care practices. We also developed 4 case studies of exemplar practices, and those case studies are available on the AHRQ website. We've identified 4 interventions and are currently working to design and develop those to improve patient safety by engaging patients and families. And in about a year from now, the final guide, which includes the 4 interventions as well as some practical implementation advice and guidance, will be available for on the AHRQ website to download. The environmental scan that we conducted identified 4 key threats to patient safety. These include breakdowns in communication, challenges around medication management, including prescribing, filling, and patient self-management of medications, challenges around diagnosis and treatment, and fragmentation of care and the environment of care. Promising interventions that we identified included shared decision-making, patient and family advisory councils, approaches for team-based care, medication management, family engagement and care, and structured communication tools. Together with our technical expert panel and our contract officers at the agency, we identified a robust model of how patients, providers, or clinical staff, and practice staff can work together using interventions and tools guiding engagement and meaningful relationship-based engagement to improve patient safety in primary care. Our approach to the guide really focused on making paired tools, and that paired tools model meant that if we gave a tool or an intervention that was focused on the patient, that we would also provide clinicians and practice staff with complementary tools in how to support the patient and family in using that intervention. The 4 interventions that are going to be part of the guide include Teach Back, Be Prepared to be Engaged, and Be Prepared to be Engaged is a patient-focused intervention looking at engaging patients and families in their readiness to participate in part of the team. Medication management and applying the brown bag method and building upon a strong medication list to do medication reconciliation and other partnerships with families, and a new intervention called Warm Handoff that helps to structure some communication between all of the team members within a primary care practice, and including the patient and family as a part of that team. The focus of today's webinar is going to be on the Teach Back strategy. So you might be asking yourself, what is Teach Back? Teach Back is an evidence-based health literacy intervention that promotes patient engagement, patient safety, and improved quality of care. It's a low-cost, low-technology intervention that can be the gateway to better communication, better understanding, and ultimately to shared decision-making. The goal of Teach Back is to ensure that the medical information you've explained is clearly understood by the patient and his or her family. In Teach Back, you ask patients or family members to explain in their own words what they need to know or do. It is more than repeating what they heard. You ask them to really teach it back to you. This approach helps clinicians, the patient, and their family member or caregiver to have a shared understanding of the information that has been shared and yields improved health outcomes as a result. Teach Back is a strategy that helps you to validate that you've explained the medical information clearly and that patients and their family members have a clear understanding of what you've told them. Teach Back is really the first step in moving towards shared decision-making with patients and families. Once you've embraced Teach Back, you can add a decision aid for complex health decisions, and you're doing shared decision-making. It really is taking that first step together towards that stronger patient partnership. You might be asking yourself, why use Teach Back? Research indicates that clinicians underestimate their patients' need for information and overestimate the ability to communicate effectively with patients. One study found up to 80% of the medical information patients were told during a standard office visit was forgotten immediately. In another study, nearly half of the information retained by the patient and their family was incorrect. Patient misunderstandings and poor recall contribute to poor patient outcomes. Teach Back is a proven strategy to ensure patients and their families have a clear understanding of medical information you communicate to them, finding ways to improve communication between you and your patients and their family members can directly address patient safety problems and fill some gaps in care. Communication is key. It is the key to unlocking shared meaning, revealing contextual factors about the patient and their current state of health and well-being beyond what you see in front of you, and will help you achieve success within the Transforming Clinical Practice Patient and Family Engagement Promising Practices metrics that we'll be describing a little bit later. So it's really bringing patient and family engagement to the forefront of value-based care. So when should you use teach-back? Generally, you should use teach-back whenever you're explaining a new diagnosis, whether or not there's a new medication need, and reinforcing the proper use and care of medications at home, any instructions that the patient may need to take with them to do self-care at home, recommending behavior changes, new treatment options, and discussing the different types of plans of care that the patient and family member may be engaging in, using a new device, next steps, and eventually at every patient visit. The teach-back process is an iterative one. First, you'll share information with the patient and family like you would do in a standard encounter. Then you would ask the patient and family to describe in their own words what they think that they heard. You need to listen in order to validate and verify so that their description of what they're describing makes sense and is correct. If it is correct, you should commend them on the fact that they got it right, reinforce that behavior, and if not, share the information again in a different way. And again, this is a cyclical process until you validate and verify that the patient and the family member understand the next steps. So how is teach-back different? You might want to say, if you ask patients questions, you don't want to have a closed-ended question. Oftentimes, if you ask them, did you understand or do you have any questions, the patient and family member may feel uncomfortable speaking up. They may just say, nope, I understand, or they may signify that in nodding. In order to embrace the teach-back approach, just rephrase that. I want to make sure that I explained everything clearly. Can you explain it back to me? Or can you show me how you can use this inhaler at home, or show me how you take your medications or where they're stored? Just engaging with them in that conversation and a little bit more active to activate them towards self-care and improved safety. So what do you need to make teach-back successful? The goal would be to use teach-back on all patients. You want to make sure that you're starting with the most important messages for the patients and families, because generally only the first 2 minutes of an encounter are those that are retained. Focus on 2 to 4 key points and use plain language and try to eliminate medical jargon. The materials that we've developed as part of the Guide for Improving Patient Safety in Primary Care Settings by Engaging Patients and Families include a quick start implementation guide, which is really a handbook to help practices start on the journey towards adopting teach-back. We have a full page guide as well as a brochure size so that you can always keep it handy. We've developed an interactive learning module for clinicians and practice staff that's available on the AHRQ website. We've also got some clinician job aids, including a pocket card for plain language, as well as a poster to keep by your computer just in case you want to have a quick reference. We have a patient poster to help them understand what you're going to be doing in the practice and now that you're adopting teach-back, and we have some assessment tools as well for practice staff. Getting started with teach-back, the first way you want to go for this is identify a champion and get leadership buy-in. Oftentimes that's the biggest hurdle to getting everybody and training up all of your team members on the teach-back strategy. To begin implementation, try it either in the first appointment of the day or the last appointment of the day. Just take it slowly and start to get comfortable with this new approach. You want to introduce teach-back to your patients so that they don't feel that they're being tested or that they're back in school. They really do want to feel engaged and partnered in care, but sometimes they need to be invited in. And the fifth step is to evaluate your progress and refine your approach. And the more you use it, the better embedded in your care process that it will be. So we do have some support for training. We have an interactive module that features case-based learning. It takes about 10 to 15 minutes to complete, and it shows you how you can use some of the supportive materials and resources from the AHRQ website. It's a fun and interactive way to test yourself and test your ability to identify that living room language and some jargon. In introducing Teach Back to patients, you really want to reinforce the message that it's not a test, but a safety check, that this is their opportunity to make sure that you as a clinician are explaining things correctly. You want to use patient materials and underline or circle important points to help reinforce the messages. Sometimes pictures or diagrams would be more appropriate, particularly with patients that may have low literacy. Ask open-ended questions and use plain language. Again, the patients and families want to partner in their care. So in terms of using this and not that, high blood pressure can become hypertension. The heart doctor is the cardiologist. It's difficult sometimes for patients and families to understand what we're saying, and it's also really challenging for them to speak up. So make it easy for them and try to think about putting yourself in their shoes. We do have some resources that we've developed for supporting that plain language. We've got some badge buddies, pocket cards, as well as an interactive a poster that helps to keep those plain language ideas top of mind. Evaluating progress may seem like it's an overwhelming and daunting tool. We've created a very simple checklist to see whether or not you're actually doing Teach Back, and for maybe even staff members to do a little bit of observation to say, yes, we've done it with that patient, or no, we haven't done it with this patient. There's also a conviction and confidence scale that's been developed, and it's available on the AHRQ website. And this is really looking at yourself as a clinician and whether or not you are confident in your abilities and skills to do the Teach Back method. This is something that we're recommending that you evaluate every 6 months and until you get confident with your ability to use Teach Back with every patient every time. We also identified several considerations with older adults. Older adults tend to have mild or moderate hearing impairments, which may limit their ability to fully engage in the Teach Back method. Some strategies to overcoming these are using a lower voice, speaking naturally and distinctly, and minimizing background noise. Older adults also have a decline in information and processing speed, so you oftentimes need to slow down the rate of delivery of new information, limit new information given at each visit, and you may want to use some strategies and tools around visual aids and additional materials to take home to reinforce those messages. Considerations with using Teach Back for children is oftentimes providers will focus the Teach Back approach on parents, which is great, but we also want to make sure that the patient themselves is being included in that conversation. So include children in developmentally appropriate conversations if possible, and ensure that both the parent and the patient and the child understand. Using visual aids to support communication is another great opportunity to engage younger children in their own safe care. There are also considerations around language diversity. So some practices may want to offer medical translation services, have both verbal and nonverbal, be aware of both verbal and nonverbal cues, and use visual aids to support any information that's being shared. Our materials that are patient-facing will also be available on the AHRQ website in Spanish-speaking versions. So at least those patient-facing materials will be available for your patient populations. So you may want to ask yourself, how can the AHRQ Patient and Family Engagement Guide help practices achieve success? Recently, back in October, the Center for Medicaid and Medicare Services identified several patient and family engagement metrics to help improve patient and family engagement and measure success with patient and family engagement at the practice level. The Teach Back strategy actually helps practices to achieve success within those metrics. It supports shared decision-making, supports health literacy, patient activation, and can also help to provide the support for patient voices and medication management. The Teachback resources directly link to items on the CG CAPS, which is one of the health literacy domains of the CG CAPS, to set you up for success in addressing health literacy. These include supporting the use of living room language, giving easy-to-understand instructions, asking the patient to describe how they would follow instructions or how they understand how instructions were given, and engaging in a dialogue about challenges to taking care of themselves and their illnesses. So why should I use Teachback? The main goals for using Teachback are to improve your patient outcomes, safer care and adherence to care plans. You'll have fewer calls to re-explain the care plan due to misunderstandings or misinformation, and oftentimes you'll have a reduction in safety, threats to safety in the patient in the home environment. You have improved patient and clinician satisfaction and increased incentive payments through public and private performance measures and patient satisfaction scores. So that's all I had to say today about the Teachback strategy. All of our materials are available on the Agency for Healthcare Research and Quality website and are available for download. And we will be releasing a new intervention approximately every 2 months. So please keep coming back to the AHRQ website and checking on all the latest interventions that are available.
Okay, thank you for your presentation, Dr. Smith. I just wanted to remind our participants to post any questions that they might have in our webcast chat box. Okay, we have a question from Patricia. Have you seen this used in dental settings?
Hi, Patricia. That's a great question. In our environmental scan, we really focused on primary care, including geriatrics and pediatrics, but we didn't necessarily look for dental settings. But I think that this approach could be used in any care practice setting, including inpatient acute as well as ambulatory care settings. So this is a strategy that could be considered to be adopted in any healthcare environment. But that's a great question.
Kelly, I wanted to know if you could share maybe some of the feedback or input that you've gotten while speaking with providers who've taken a look at this intervention.
Sure, absolutely. We've had, as part of our process, we brought clinicians, patients, and family members, as well as practice staff together in a process of co-production. So before we even started focus testing, we engaged the end user in the development of some of our tools and materials. Primarily what we've been hearing from those groups is that while Teachback may take a little bit more time at the beginning because clinicians need to rewire their standard conversation speech that they have wired in and been using for many, many years, Teachback in and of itself can start to reduce the amount of time and the burden after the clinical encounter. So part of our, one of our case studies that we spoke with actually used the Teachback strategy in addition to decision aid to improve antibiotic stewardship within their practice. And what they found is that even the clinicians that may have been skeptical at first when adopting this particular practice, once they got on board, they realized that it did save them a lot of time and effort in convincing patients that they may or may not need an antibiotic for an upper respiratory infection that wouldn't necessarily be treated with that. So over time, our general users have already wanted to start adopting the materials before they've gone through our focus testing and been formatted for the AHRQ format. So we've been getting very positive feedback on the materials so far.
Great. So you answered some of the, you discussed maybe one of the barriers, but Patricia also asks, what are some of the other biggest barriers to adoption?
Sure. I think across all the interventions, time is the biggest barrier. to adoption. We believe that the teach-back intervention from the four interventions that we're working on, the three that are really finalized and moving forward, teach-back is the least time-intensive. So that's why we're really recommending practices start with teach-back. The next intervention, be prepared to be engaged, is also an intervention that is really low time intensive for practices. It's more time intensive for patients. So that will be the next sort of step in the process of patient and family engagement. But time is really the biggest barrier. That and potentially clinician behavior and hesitance to believe that this is actually just going to take a little bit more time. They may not have the softer skills to be able to engage with their patients and families as intended.
Okay. We have another question from Mary Ann asking, would you mind giving the site for the materials, just kind of saying it, and then I can maybe type it if you have the link offhand, or?
Sure. The link is on one of the slides, and we created a smaller bit link for it, so let's just pull that slide up. It is http://bit.ly/2FMU capital NYE.
M as in Mary, Y-E?
N as in Norman.
Okay. Okay, thank you.
And all the materials for the first two interventions will be available at that link.
Okay. Another question from Nancy. Will motivational interviewing be an intervention released in the future?
Nancy's right on track with this. Motivational interviewing was one of the interventions that all of our co-producers, our technical expert panel, as well as all of us on the development side really felt is an essential skill to be learned. Unfortunately, the goal for this particular toolkit was to provide practices with something that would require low technical assistance. And our teams felt that motivational interviewing, because it's a skill, required more of an experiential learning approach and maybe a little bit more challenging to learn from a book. And so that is something that we have heard a lot about, and we will have a note of resources for advanced practices as part of the final guide that will direct people who are interested in doing some more advanced learning on things like motivational interviewing. We'll direct them to resources that exist already for that.
Okay, great. And from Dr. M, have there been studies showing improved metrics for diabetic insulin patients or albuterol asthma patients, i.e. improved health, less hospitalization?
Using the teach-back strategy? I can't think of any right off the top of my head, but I'm sure that there have been using the teach-back strategy in engaging patients with chronic disease management. Because we were specifically focused on patient safety, we didn't really take stock of all the different chronic diseases that teach-back has been used in.
Okay, and we have another question from Mary Ann. Has this been tried with patient groups rather than one-on-one?
That's a great question. I don't recall from our environmental scan seeing the use of teach-back in patient groups, but it would make sense that the same approaches using open-ended questions, active listening, and the skill set of particularly engaging in motivational interviewing in a group setting should be translational. So it could move from a one-to-one or a two-to-one communication to more of a group setting.
Okay, question from Angela. You talked a lot about visual aids to support communication. Are there certain types of visual aids that work better for children and certain types that work better for older adults?
It's a great question. Generally, what we're looking for in a visual aid is something that is geared to the literacy level of the receiver. There's a couple of websites and sort of accumulation of decision aids that are available that are targeted towards either older adults or children, and those will be included as links in our sort of guide to advanced practice under the shared decision making. There are a couple of great resources coming out of Ottawa. The Ottawa Health System has a phenomenal data bank of decision aids that are available for every sort of chronic disease and that are geared towards different levels of learning.
Okay, thank you. From Nancy, are you advocating any particular teaching tools like zone or stoplight tools, or can you recommend any other best practice educational materials?
I think from an educational perspective, if you're taking Teach Back in complement with a decision aid, some of the advanced practice guide materials, once they're available, will help to direct you to sort of disease-specific or literacy-specific approaches to help patients come to a joint decision with their caregiver.
Okay, thank you. I believe those are all of the questions that we have for today. Thank you very much, Dr. Smith, for presenting on a very interesting topic. I think our participants were very engaged in their questions. To anyone who would like to obtain CME credits, please stay on. I'll be posting the link in just a few moments. Thank you for everyone for joining, and have a happy holiday season.
Thank you.